Hello and welcome to Cafdil Healthcare on Cafdil TV. I am Kojo Arthur. Tonight we are looking at the important role the radiology department plays in the management of breast cancer, from early detection to diagnosis to follow-ups care. Stay with us for key insights on or into how imaging saves life. I'll introduce my guest right after this break. Stay tuned.
Time immemorial, God has always communicated himself and his will through various voices: the prophets, the kings, the judges, not forgetting John the Baptist, who was a precursor to Jesus Christ and gave us the will of God. We bring to you Voices from the Valley. This is a program designed by the Conventual Franciscan Friars in Ghana in collaboration with Cafdil TV to bring you in-depth insight in our faith, catechesis, and various Catholic teachings which will help you in your journey as a pilgrim. I know you cannot miss this program, and I highly encourage you that you shouldn't miss this program because it is Voices of God from the Valley of Prayer and Silence. Join us this and every Sunday at 3 p.m. and a repeat on Wednesday at 7:30 p.m. here on Cafdil TV and on our various social media platforms: YouTube, Cafdil EDU, and Facebook, Cafdil Cape Coast. Let us meet and share what God has for us through the Voices from the Valley.
Make me a means of your peace.
Welcome back. If you just tuned in, this Cafdil Healthcare on Cafdil Television. Like I said, tonight we're going to take a look at the role the radiology department plays in the management of breast cancer. So I have with me Helena Amewode. She is a radiographer at Cape Coast Teaching Hospital, and Baba Onuma, also sonographer, Cape Coast Teaching Hospital. Beautiful ladies, you are welcome.
Thank you very much.
Thank you very much.
So we are radiographer, sonographer. You are sonographer, you are radiographer.
Yes.
So tell me what you do, then you also tell me what you do, because first we have to know a clear difference between the two. Okay. So let me say yes.
So as a radiographer, our main aim is to provide patients with diagnostic images. So we work with imaging modalities that use both ionizing and to take images of the human body. So we have modalities such as the CT scan, the MRI, which is magnetic resonance imaging, the mammography or the mammogram. Yes,
okay, so the radiographer uses those machines.
Yes, please.
What about the sonographers?
Okay, thank you. So the radiography is like the bigger body, and the sonography is like one aspect of radiography. So mine is like you taking one part of radiography, and then I've specialized in that. So we do with ultrasound. So taking scans, yes, abdomen, any part of the body at all. The ones usually the pregnant women take, yes. So that's my part.
Then you do a lot.
Yeah.
So some can also take. So how many components that all of you or anybody can specialize in?
Yes. So like I said, it's broad. Like we have the X-ray part, we have the mammogram, we have the MRI, the CT, and ultrasound.
Oh, okay.
So you can choose any part where you want to.
Right.
But usually in Ghana, we just have the radiography and then the sonography.
So again, walk us through. We want to start our conversation in a very simple way. Walk us through the role your department plays when it comes to breast cancer. Yeah, Baba.
Okay, thank you. So, with imaging, I think ours has to do with the detection and then the diagnosis. That's the basic, the early stages, like the primary. So we deal with being able to detect, okay, there's a lump here or there's a lump there, this is it. And then we describe, okay, so it's looking like this, it's looking like that. Is it cancerous? Is it not cancerous? So that's where we come in. So right from the early stage, if a patient comes in and then, explains, I have a boil or a lump in my breast somewhere, then they come for a scan. So we will tell them, okay, it's located here, it's located there, it's made up of this or that, whether it's hard, it's soft, it has this or it has that. So that's where we come in. Like I said, so right from the beginning, we are able to detect it and we are able to also diagnose it. Okay, it's cancerous, okay, it's not cancerous. Before now, the doctors will take it from there for management and then for treatment. So, yeah.
What do you want to add?
Okay, I would add a little. So in the radiology department, we have, aside with the radiographers and sonographers, we have the radiology nurses that also help in checking vital signs of the patient and other, let's say, drug administration during any procedure. We also have the radiologists, and we are doctors that specialize in interpreting the images we take. So after a radiographer or a sonographer has taken, let's say, a CT scan or a mammogram, the radiologist does just write a report on the images we get from the mammogram. So he will just write a report on the findings we, the radiographers and sonographers, will get. So these reports are being sent to patient. The patient will send it to the doctor for further diagnosis or evaluation of the disease.
So what means this month is breast cancer month.
Yes.
So the one that you if you don't if the person doesn't come to you, then they use hand to detect. So this is very advanced anyway.
Yeah.
All right. So for someone watching at home, how important is radiology in catching breast cancer early?
Okay, so I would say radiology is very essential in catching breast cancer early, in the sense that when you come early to the hospital and we screen you for breast CA, if after the investigation we see that you have a breast cancer, at that point the breast cancer, let's say, is a very small, has affected a small portion of the breast. So then it means it hasn't spread to the other organs yet. So it helps the doctors in treating it faster. So in the sense that if you wait for the breast cancer to aggravate to a very end stage, there are some treatment options that are very aggressive, in the sense that it can even lead to the surgical removal of the breast, also called mastectomy. So if the breast cancer is detected early, treatment plan starts at the very point.
Maybe they've heard people say it, maybe they've heard people say it, maybe they've had family members have it. So I would say that they shouldn't fear. It's better when you come and then we do the scan and then we tell you that, okay, it's normal, you have to go home, or maybe it's early stage, so they have to do something quickly to get rid of it, than to let fear or the myth take over and then you stay at home. That's why we ensure, or we always hit on the fact that early detection is important. So whether it's small or it's big, you should come, and then the earlier you know, the better. Yes.
Now, you made mention of the myth. Have you heard some of the myth that some of the myth that you use this opportunity to debunk those myths?
Yes. So usually, if somebody has anything to do with cancer, they'll be like, okay, spiritual, or if but usually it's not like that. Cancer is DNA or cells related. It's like you having, let's say, a nut in a bowl, and then one nut goes bad. So if your DNA and then you have one cell in your DNA that goes bad, that is what brings the cancer. So it has nothing to do with spirituality, or even somebody doing anything to you. Yeah. It's just your cell or your DNA that is, and our body parts is some way. You can't really tell when this is going to happen or when that is going to happen. And most of the times it happens when, usually people say that, okay, if you have an encounter with somebody and then the next month or the next week you start feeling that, oh, okay, maybe I had a fight with this person, so it's this person that is now doing me. No, it shouldn't be like that.
Yes, like
yeah, exactly. Then the next week you're already feeling like, hey, did this person no, but it's not like that. So I would encourage that we should put that kind of spirituality aside a bit. You come to the hospital, let's see if everything is okay. Then you can even add both. Nobody is saying that debunk the spirituality and then just do medical.
Because it's also real.
Yes.
Yeah.
So you can come to the hospital, let us check, and you can still take it to prayer.
All right. Okay, so Helena, you made mention of mammograms, and in fact, we also hear a lot about mammogram. So can you explain what that is and why it is so important?
Okay, so mammogram is an imaging modality that uses a low dose X-rays, meaning it's really safe for pregnant women. So this low dose X-ray will take an image of your breast tissues. It really helps in detecting breast cancer even after an ultrasound is done. So let's say it's an advancement of a breast ultrasound. So it works by allowing X-rays to penetrate through the breast, then we see every single details. Mammogram is really important in the detection of cancer because there are some abnormalities that the ultrasound cannot pick. So then a mammogram is requested for it to pick those very little details. So it really helps in the diagnosis.
It is low.
A low dose.
What is a low? What is
So basically, from all the radiography sections or modalities, we use radiation. So I'm saying it's a low dose because in some modalities, such as the CT scan, you use a high energy of radiation. So the mammogram has to do with a very small amount of radiation passing through the breast. So then it's safe for the use for everyone.
So if the thing is very small, that
it can
mammogram
penetrate.
can
Yes,
pick.
please.
Oh, okay. That's why you say it's even safe
For pregnant people.
Oh, okay. Then is, but are people making use of it?
People really make use of it, but the problem is we don't have a lot of mammogram machines in the country.
In the country?
Yes, please.
Whoa. So, like CCTH, we have some.
Yes, but it's faulty at the moment.
Oh, okay. All right. So anyway, but let's go on. Baba, at what age, I want to know, should women start coming in for breast cancer screening, and how often?
Okay. So I would say that these days the guidelines are changing. Initially, it used to be older women. If you are, you say 40 years and above, you come in for a mammogram twice a year, or sometimes even once a year. It depends. But these days, we are in a modern world, all right. But even younger women are now developing breast cancers, and it's becoming very prone. They say 1 in every 8 women are getting breast cancers these days. So usually we'll start from, I would say, 25 years. But at 25 years, you don't really take the mammogram. The mammogram is for, if I'm allowed to say, the breast that is a bit saggy. That, yes, I'll say the breast that's a bit saggy. Yes. And then the ultrasound is for women with firm breast. So the ultrasound is recommended for the younger women, 25, 26 years.
But some of 20, in fact, 20 cries. Like,
I don't know about that one yet, but
but so what I want to say is this is not for don't bring in the age because some of the even 15, 16 cry. Born at 25 and cry done.
Yeah. Okay. So usually the younger women, we recommend the ultrasound scan for them at least twice a year or even once a year when you don't have any symptoms at all. It's like on just a normal day. So it can be every October in a year when you hear about breast cancer screening, you go there, take your scans, get screened. Yes, and then when you're 40 years and above, once a year, come in for a mammogram and then also do your screening.
So why do you think the trend is changing? Why? Like you said, at first it was 40 years and above. Why do you think now it is 25 years and this? Why?
Okay. So I would say that lifestyle these days is very important. Sometimes a parent, let's say if I give birth and then I have this kind of cancer cells in my DNA, automatically I transfer it to my child. So if I have cancer, let's say at age 40, my daughter might not have it also at 40, but she might get it at 25 or 26. So now it's a transfer of DNA and also the lifestyle. The drinking, smoking, all these things, they cause, yes. So I would say that, because these days, there's not much regulation because people say that leave your children, don't lash them, don't cane them. So they do all kinds of things that they want, and then it ends up with cancer and then other things.
So, Helena, in your opinion, what do you also think that instead of 40 years, we are down to 25 and even 20?
Yeah.
And even we say that when October, breast cancer, when we hear that you are doing this breast cancer screening, any child or any girl with breast should come, irrespective of your age.
Okay.
So what do you think, in your opinion, has changed this old to the younger age?
Okay, so I think in my opinion, these days, as my colleague earlier said, if somebody has a family history of breast cancer, not necessarily my mother passing it on to me, it could be my grandmother who is dead or something. So it's in the family. So people with known family history of breast cancer are more prone to the disease. So somebody like that, if you are, have a family history of that, and you also feel breast changes in your breast, I think it's early. It's better you come for the screening. Aside we saying that when you are 40 years and above, it's good for a mammogram, and we are below or premenopausal age, you need a breast ultrasound. So I would say family history also counts in. And these days, I think there's no particular age. I would say there's no particular age. But when you see any breast changes in your breast, I think you should just come for a screening for a better side.
Not necessarily lump.
Well, there are other breast changes. So aside the lump, we have people experiencing nipple discharge, people experiencing pain in the breast without you doing anything. All these signs are signs of breast cancer. So when you experience these changes, you can just come into any facility to have a breast ultrasound. So if there's a need for a mammogram after the breast ultrasound, the doctor will request that for you, then it helps in your disease diagnosis.
You made mention of breast discharge. So if mistakenly a guy, suck or lick the discharge, is it also going to be transferred to the...
No, please. So breast cancer is not transferable like that. As my colleague earlier said, she said it has to do with the cells and the DNA. If it's transferable, like we, the ones at the hospital, will get it, because sometimes when you are doing a mammogram for a patient, the discharges come. So, but still you need to compress, so we get into contact with it. But breast cancer is not transferred from one person to the other through contact or anything.
Brothers here, one be,
No.
one woman discharging one it will affect them in any way. But how does catching breast cancer early, through imaging, makes a difference in treatment?
Okay, so for imaging, we have a lot of modalities that help in early detection of breast cancer. So sometimes a patient or a woman can do a physical breast examination and will not see any form of lump or anything. But when we do ultrasound or mammogram, there are some little things we call microcalcifications that can be detected on the mammogram but cannot be detected through physical examination or ultrasound. So in the if you incorporate imaging in breast cancer screening, it really helps detect these small abnormalities that will not be seen on a physical examination.
So do you use kind of advanced machine in your department?
So currently, no. We are a bit still in the olden days.
Not necessarily our department, it's the country
itself.
itself.
The country itself,
Okay.
yes. You barely find...
the department, the department in the whole country.
Yeah.
Your
Yes.
department in the whole country.
Okay.
They use the machine.
Yeah.
And do you use some advanced? I just wanted to know if you can explain the different types of scans you do in your department.
Okay, so basically we have the CT scan, which is a computerized tomography, which uses a high energy radiation to image the part of the body. We have ultrasound, which uses...
So let's say one by one.
Okay,
CT
please.
scan.
Yes, please, CT scan.
What is it used to detect, actually?
Okay, so CT scan is used to detect a lot of abnormalities in the body. So depending on the patient's history, a doctor will recommend a CT scan for you. So a history can be an RTA, which is a road traffic accident or a trauma. Let's say somebody falls from a height and breaks his hand or his head, a fracture in the head. So we would want to take a CT scan to see if the fracture has any effect in the brain tissues. So the brain tissues could be, let's say the blood vessels could burst and cause a bleed in the brain and all that, which is very life-threatening. So the CT scan, when a patient like that does a CT scan, we're able to detect the bleed and do any other treatments to save the patient's life. Aside the bleed, to people who have cancer, cancer can spread throughout the body. So as we are talking about breast cancer, if it's not treated early from the breast, it could spread to the spine, the abdomen, then it means it is worsening. So when you do a CT scan, mostly we see because something metastasized, so the cancer will move from one place to other parts of the body. So the CT can be able to detect all these traits of the metastasis of this breast CA. Yes, please.
Then you were going to mention another one.
Yes.
Is that M?
The MRI, which is magnetic resonance imaging.
What is it also used to
Okay,
detect?
so it's used to detect soft tissues. So basically in the body too. So depending on the patient's history too. So there are some patients that they come with, so I say migraines, and we do a CT scan and we don't see anything. It looks fine. The CT scan shows normal. But when you do an MRI, it goes deep into the blood vessel, so we are able to detect some early signs of or whatever is causing the migraines.
Baba, do you? She has given me two. Do you have more different types of scans you do in that department?
Yes. So mainly I work with ultrasound, so I will talk about ultrasound.
Ultrasound.
Yes, and I think
so. Is the ultrasound is different from the MRI
Yes,
and
yes.
the
CT scan.
CT scan.
Yes.
Okay.
so. Ultrasound, I think it's the popular one amongst it all because it's cheap and then it's everywhere these
Cheap
days.
in terms of
The
cost.
pricing, the cost. You coming in, yes.
I thought ultra is something advanced than the.
No.
Oh,
So the
okay.
ultra here has to do with the sound being ultra. So like it's a high,
High
sound.
sound.
Yes. Ultra as in high. Yes. So with the when relating to cancer, the ultrasound will rather tell you whether the lump you are seeing in the breast, if it's fluid filled, or if it's cystic, or if it's solid. So like if you have a lump, usually if you can feel it, but you will not be able to tell whether it's fluid filled, whether it's hard, whether it's soft. You can just feel like there's a lump. But the ultrasound will tell you, okay, is it even circumscribed? Is the shape well defined? Is it not well defined? Is it one? Is it two? Yes, that's what the ultrasound will tell you.
Then what again? So we have had three.
And then there's the
Mammogram.
mammogram. Yes, I think she will speak
Yeah,
more on the
Oh,
mammogram.
so what is it also used to detect?
Mammogram is basically breast imaging. So it's also used to detect any abnormality in the breast tissues. And mostly it's after a breast ultrasound has been done. So it's like an advancement or for you to know, get a better evaluation of whatever you found on the breast ultrasound. Then a doctor will request a mammogram for you.
Now, mentioning ultrasound, Baba, when would you choose ultrasound over mammogram or even MRI? At what point?
Okay, so I'll bring in the age factor
Because
again.
you said it is popular.
Yeah.
Yes, yes. So it's aside it being cheap, and then it's been easy to access. Mostly has to do with the density of the breast, like I was saying earlier, with whether it's saggy or not. Because the ultrasound needs, the breast has to be firm, or let me say the mammogram, because of, so if my colleague here will demonstrate this, you put the breast on something like a plate and then you compress it to take the image. But if the breast is dense or if it's
Plate. Which of
firm,
the plates?
so that's how the
Any
machine is.
flat?
Yes,
Yeah.
it's like a flat surface.
Auntie,
On
what
the
is
machine.
In your hand or the
that?
loop now to the hand, then yes, then you take the image. But
That
ultrasound,
is a saggy one.
yes. But the ultrasound, you have to lie down, and then they'll use the machine to kind of go around the breast. So if your breast is saggy and you're lying down,
It will also,
yes, and I don't have to raise it. Yes. So usually the ultrasound is for the firm ones where you can
Okay.
just go all around. And also if you are going for a mammogram and then the breast is firm, you can't really do the compression. Yes. So that's when you do that too.
But have you checked, both of you, have you checked for the breast cancer this thing? Have you checked
I have
yourself?
done the screening, yes,
Physical
self-examination, yes.
Which machine did you use?
No, the self one, the hand
the
one.
self-one.
Yes.
Yeah.
But why are you not using the machine, your own machine?
No, so I think the machine comes in when you find something.
Yeah.
So you do the self one, or somebody will do it for you. But it, oh, okay, I feel something here. So that's when you go and do the scan or the mammo to tell you that, okay, this is this or this is that, yes. But a normal day, you're supposed to do the self or the physical one first. Yes.
So I would add a little to what she said about the, I think for patients or women from age 40, that's the postmenopausal age, we have a type of mammogram called a screening mammogram. So for them, after the self-examination, and you don't find anything abnormal in the breast, you can still go in for the screening mammogram. Because earlier I said a mammogram can detect the little or minute details. So then it's safe for them, because we earlier said it uses radiation, and at their age, that time the breast is not that dense. So for a postmenopausal age, like the 40 years and above, a screening mammogram once a year really helps after the self-examination is done. Yes, please.
But is it costly?
For mammogram,
Yes.
I would say it's expensive more than the ultrasound.
The NHIS doesn't cover
No,
anything
please.
about
No,
your department.
no, please.
All right. 3D mammography.
Okay.
How does it help?
So the 3D mammography is also known as the digital breast tomosynthesis. Aside the mammogram being able to detect the little minute microcalcifications, the 3D is like an advancement of the 2D mammography. So that one, it shows images in several planes. So let's say when we use a 2D mammogram machine to take a mammogram of the breast, it can hide some little details, but the 3D will show the image of the breast in several details. So every slice will show whatever it entails. But currently in Ghana, we don't have the tomosynthesis, so we manage the 2D mammogram for now.
Hey, Ghana. But it also helps, right? The
Yes,
2D.
yes, please.
It's also help. But you radiographers are behind the scene a lot.
Yeah.
We don't hear from you. You are behind the scene, but you also play a major role.
Yeah.
Okay, so tell us what your day looks like.
Okay, so most of the times we say radiographers and sonographers, we are the eye of medicine. We are the ones that produce images of the human body, because when you're here, you don't know what exactly is wrong with you. But when you come to us and you take x-rays and ultrasound, then we tell you, or you find out any abnormality wrong with you. So when a patient comes during the day, let's say I come to work this morning, mostly we speak to the patient about what to expect during the scan. So if it's an ultrasound the patient is coming to do, we tell you the waiting time, the things you're supposed to do when you come inside. If it's you going to lie on the bed and raise your hand, and what the sonographer is going to do, the importance of whatever is going to do. If there's any risks involved, let's say you feel a little pain, we tell you all that. After that is done, we take the scan or the x-ray. When you are done with that one too, we print the x-ray film or the scan reports for you. If there's a need for a radiologist to interpret the images we've taken, then we send these images to the radiologist. He or she works on that and brings us a report. Then we give it to the patient for them to send to their requesting clinicians. So
How long does it take?
And depending on the x-ray or the scan you're coming to do, then we can tell you the time, because all of them do not work within the same time frame. Some can take like 5 minutes, some can take more than 30 minutes. Yes, please.
Among all the departments in a hospital, your departments do well.
Yeah.
Because I remember once I was asked to go for this CT scan.
Okay.
They gave me a time. I think there was a light or something.
Okay.
They asked me to go home. I went home. So 2 days later, they called me to come. In fact, I was happy. Some department will not call you. You would have to go yourself and check.
Yeah.
But for you do a lot. So you're still watching Cafdil Healthcare on Cafdil Television, and we are looking at the role of the radiology department in the management of breast cancer. We'll be back after this break.
Time immemorial, God has always communicated himself and his will through various voices: the prophets, the kings, the judges, not forgetting John the Baptist, who was a precursor to Jesus Christ and gave us the will of God. We bring to you Voices from the Valley. This is a program designed by the Conventual Franciscan Friars in Ghana in collaboration with Cafdil TV to bring you in-depth insight in our faith, catechesis, and various Catholic teachings which will help you in your journey as a pilgrim. I know you cannot miss this program, and I highly encourage you that you shouldn't miss this program because it is Voices of God from the valley of prayer and silence. Join us this and every Sunday at 3 p.m. and a repeat on Wednesday at 7:30 p.m. here on Cafdil TV and on our various social media platforms: YouTube, Cafdil EDU, and Facebook, Cafdil Cape Coast. Let us meet and share what God has for us through the Voices from the Valley.
Make me a means of your peace.
Welcome back. If you just tune in, this is Cafdil Healthcare on Cafdil Television. And let me come to you, Baba. And some people are nervous before coming in. Yeah. And not some people, most of us. We are nervous before. So how do you help patients feel safe and comfortable during the scan?
Thank you. So first of all, I would say it's the way you talk to somebody that will help the person to calm down. So imagine if somebody is coming in, let's say I did a breast, a patient did a breast, myself one at home, and then the person noticed something in the breast, and then already you having that thought that there's something in the breast can make you feel nervous, like, okay, are they going to say it's cancerous? Like, you're already doubtful. So imagine if you come and I'm also like angry from somewhere, and then, oh, please lie down, I'll just talk to you anyhow, and then, no, it will not be nice. So mostly it's how you approach the person.
Be professional.
Yes.
Yeah.
It's how you approach the person, even without knowing what is wrong with the person. If you approach the person in a very nice way, already they are calm because they feel like, okay, maybe this lady is friendly or this guy is friendly. So now when they come in, they lie down, and then even before you begin the process, I think when they come, they usually come with a request form. So there's history on it. So you have a fair idea of what is going on. So you talk to them, oh, there's this on your request, I want you to relax. It is not painful. It is not this. You talk through them. You talk to them through the scan. And even whilst you are doing the scan for them, you are still talking them through, oh, it's just relaxed. It's nothing. Even if there is, these days, we are in a modern world. Everything is solvable. You can get rid of it. You can do. And then whilst you are doing the scan, it's easier when you tell them that, "Bibi, fine." Like, excuse me to say, like, everything is going to be okay. So.
Oh, but no problem. If you want to speak, I'll look at it. No, but it's allowed.
Yeah, so it's like you talk to them through the scan. You don't just leave them to their thoughts. So what should I, and then sometimes your facial expression, yesterday like this, I went to do a screening for some people at a bank breast. And then one lady came in.
Cell phone?
No, with the ultrasound.
Oh, so ultrasound is movable?
Yes, it's movable.
It's mobile?
Yes, it's mobile.
Oh, really?
Yes, we have machines that look like laptops that we carry them around. Yes. So whilst I was doing the screening, I was doing the breast for her. So I think I was done. So I was going to mention her name and be like, okay, I'm done. So I was like, I mentioned her name, Grace. And she said, ish. Like, she was scared. I'm like, oh no, like just calm down. So from the talking, and they're already nervous. So you talk to them nicely, you approach them nice, tell them that it's going to be okay. It's not a problem. Even if there's a problem, doctors will take off it. You'll be okay. Then I think they would calm down. Some people, no matter what you say, they will still be nervous. Like they will still be, but it's all. You cannot always solve their nervousness, but you do our best to make them calm down. Yes.
But Helena,
Yes, please.
can someone walk straight to your department and say, I'm coming to do this, either ultrasound or MRI? Can some, or it need to be, a doctor need to be recommended?
So basically, most of our procedures, a doctor, or you have to go to a clinician or a physician for him or her to request an imaging procedure for you, because we have a lot of imaging modalities. So they know your condition. They will take time to prescribe the best modality for you. So let's say you do a screening mammogram, a physical screening on your breast, and you realize there are lumps. You just go to the nearest clinic or hospital. You explain whatever you find in your breast to them. Then they can write a request form for you, telling you to go and do an ultrasound or a mammogram. Yes, please.
But if you have a lump, you cannot just see it physical.
Or you can feel it.
No, I mean without you touching it, you can't see it.
No,
I'm not sure.
there's no. You cannot see it unless you touch
Touch
it.
it.
Yes. And then if I add a little to what she said, when they coming in, usually if you walk in, we might write a request for you. We'll do it for you, but sometimes we will explain, and then the patient may not understand. So instead of, if you give them the report, instead of them to take it to the doctor, then now they take it to their pastor or to do with it. But you give them the report to take to the doctor. That's why I usually recommend to go and see the doctor, because afterwards you have to go and give the report to him back. But if they walk in, you do it for them. And even if you tell them to go and see a doctor, don't go. They'll just be going forth and back with their reports. That's why we always advise that you see a doctor. They know what machine or what procedure is good.
Best for your
yes,
condition.
for you. Yes.
But is there any special training needed to work in the breast imaging?
Yes. So we are from UCC Kenya, 4 years. So she's a qualified radiographer. I am a qualified sonographer. So even after the 4 years, there's a license exam that you write. So you can't just go anywhere at all for a breast examination. You have to go to a very qualified person to do it for you.
So I'm wondering, all these things that you are eloquent about, and our machines as well we do. So how are you able to use all this? First, we don't have the machines and that stuff in Ghana.
So it's not if the machines are there, but some of them are faulty. And it's not all of them. So if you take our place, for instance, we don't have the mammogram, but we have the CT and we have the ultrasound. Yes. So if you come in, the ultrasound is there. You can make use of that. So it's not like we are just there and then we are not using any machines. There are machines there. Yes.
What about mammogram?
So even if there is no mammogram, after a patient has done a breast ultrasound and he or she needs a mammogram, after the doctor has requested it for you on your request, you can go to any nearest facility that has a mammogram and go and do it there. Then you bring the report to the doctor that requested it for you. Then the treatment plan starts from there.
Your work is supposed to be a collaboration with other departments in the hospital. So how do you work together, with doctors or surgeons, other departments, when a patient is diagnosed with breast cancer?
Okay, so it's like a food web. Somebody has to feed somebody for the next person to feed somebody. So let's say right from the beginning, you go to the OPD. The OPD nurses will check your blood pressure and all those things, and then they will take you to an OPD doctor. You will tell your history to the doctor, and now the doctor will now recommend you to us, the radiographers. They will also do what we have to do. We take the scans, and then we write the reports. Okay, this is cancerous. Okay, this is not cancerous. Then you take it back to the doctor. So let's say if it's found to be cancer, you take it back to the doctor. The doctor will now to recommend you to an oncologist. So it's like from one point to the other, and that's how we all work together, because the nurse has to check your pressure and all those things to take you to the doctor. The doctor has to bring you to us. we to the doctor. So we are kind of interchanged. Yes, that's how it works.
All right. So what usually happens, right, from the first scan to when a diagnosis is made? What happens?
What happens? Can we take that again? Like
I mean, share with us in simple steps.
Okay.
In simple steps, what usually happens from the first scan to when a diagnosis is made?
Okay, so mostly if a patient comes in, okay, you take a breast ultrasound, and there's a need for a mammogram or an MRI. Means after my colleague, she's a sonographer. Let's say she's imaged somebody's breast and the person has breast CA. So, or she finds some signs that look like breast cancer. She might recommend in her report that a mammogram is recommended. So if the patient takes the report to the doctor and the doctor sees the essence of the mammogram, then the patient will come to me. I do the breast mammogram. After that, I give the mammogram to the radiologist. These radiologists are doctors that write reports on the mammogram and other imaging modalities. So aside the radiologist writing a report on the mammogram, he will do a complementary breast ultrasound to be sure that the detection or the abnormality she saw on the ultrasound and what I am also seeing on the mammogram correlates. So after doing this, he also writes a final report. So after the final report is written, the patient would then send it to the doctor. If there's a need for any oncology services, like she said, that's mostly in the end stage of the breast cancer. The oncologist will recommend either a radiotherapy, that is the use of high energy radiation to kill the cancer cells, or a chemotherapy, that's also the use of drugs to kill the cancer cells. And in worst situation, there's mastectomy. That's the surgical removal of the breast. And we should also know that if breast cancer occurs in even one breast, because we have lymph nodes in the body, it can transfer from the left to the right and even to other parts of the body. Yes, please.
So, Baba, in every situation, every department, there are challenges and tough situations. So, what are some of the tough parts of working in this area that you ladies have chosen? Any challenges you face regularly?
Yeah, so for my part, I would say is the understanding and the education behind breast cancer. A patient will come in, you detect something, you might not even let them know at the point because you feel like, okay, if I tell them, they might not even go to the doctor or they'll just interpret it as something else. But they'll also force you, be like, hey, you won't cash and share me, like trying to force words out of your mouth. So I think that's my part where I find it hard telling them that, because I can't come straight ahead and tell you, okay, this is cancerous, or you have.
Is it against your rule? Because you've written a report. Can't you tell the patient what you have written?
So usually we do the scan and the report comes afterwards. So they want, like, right after the scan, they want you to tell them what is in the scan. But normally it's not like that. If I'll take an example of a woman I did a scan for, and then that person, I had to say what was wrong. Like I had to say, like she was just forcing the words out of my mouth. I said it. And then she cried and she never left my bed. Like she was there, she was wailing up and down. So from then I said, I will never tell any patient what is their problem again. So I think that is the hard part for me, having to deal with people that don't have the understanding that it is not really in my position to say anything. You have to wait for the doctor to tell you these things, but they never agree. They want you to say it right then and then. So if it happens that you say it, they don't even take the report anymore. They already know what you said, so now they'll leave the report and then they'll go, which is very bad.
But do you have a situation where in some hospitals you don't get, the patient don't get there, they will just direct you to go to a doctor and the report will be sent through
the LIMS.
Yes,
the LIMS to the doctor. So when you go to the doctor, then the doctor will tell you this. But in your situation, look, listening to you carefully, it means you have to print the report, give it to the patient to be taken to the or to be sent to the doctor. That is where you get those.
So usually we do the two. We give you a hard copy, and we also have the LIMS system where we upload what we've typed onto the LIMS for the doctors to have access to it. So more of the hard copy has to be like it's yours, to have an evidence that, okay, I came for a scan. Because if we have the soft copy, you might not really know Or you need to have an
But
evidence.
then the copy can be printed at the doctor's office.
Right.
So that you will have your peace of mind.
I think that would be more because the doctors can be
Yeah.
printing. Yeah, it won't really be. Yes.
Helena, you also have certain challenges
challenges.
that you face in your department.
I would say emotional challenge, because sometimes most of the patients, for those who come for mammogram, they wait till like the cancer has really gotten to the end stage before they come. So when they come, most of them, they have a swelling breast, a very painful one. So when you try, and the mammograms, you need to compress an amount of the breast tissue so that it will spread evenly on the plate for you to be able to detect. So when the breast is now hard and painful, when you touch, when you're compressing, they feel so much pain. So whilst you are compressing, be like, oh, mama, kafra, we'll finish soon. Sorry about that. And sometimes it's bothers me.
Do you use your hand or is the machine?
So you spread the breast on the machine
That
with your
plate.
hand. So you
With
use
your
your breast and just spread it on the machine. So sometimes you just have to encourage them that you be done soon and all that. But I feel so bad that they wait till the end stage before they bring it, because I know the treatment plan will now be difficult, and it can even lead to the removal of the entire breast too.
All right. So to make your work very simple, easy, I mean, what should a woman know before coming in for a mammogram or breast scan?
Okay, so I'll talk about the mammogram. So before you come for a mammogram, we'll book you. It's based on appointment. So on the day that you are coming, you're not supposed to use deodorant or any antiperspirant underneath your armpits or any powder.
Does it have effect?
Yes, please. It has an effect on the images we take. Sometimes the powder in these deodorants, it mimics the microcalcifications. Yes, so we tell them to avoid these things, and we also tell them to wear loose dresses, because when we come, you ask you to remove your dress, then you put your breast on the imaging plate. So imagine wearing tight dresses. Now that you want to try to remove the dress, and we give you a hospital gown to wear too. We also advise them to remove or avoid wearing long earrings, necklace, and watches.
So this information is supposed to be a pre-information.
Yes,
How
please.
do they get it?
So that's why I said on the mammogram is based on appointment. So the day your doctor will request for you, you come to our department. We give you a day to come.
Okay.
So the day I'm giving you, I tell you all these
All these
things
things.
and what to expect during the mammogram. So
What about
Ultrasound, you don't really need much preparation. You just have to walk in with your request form, and then when you come, we'll ask you to lie down, remove your dress, and then we'll go ahead. So ultrasound doesn't really need that much preparation, yes. And it's quick. Ultrasound doesn't take much time. I think under 10 minutes,
should be done.
you should be done with it. So yes, they shouldn't be scared or they shouldn't be nervous. You can come in anytime, any day for an ultrasound scan of their breast.
you may have had experience in encouraging some of them to still come for the screening, right?
Yes.
And because some of the women are very much afraid. Yes. So here, giving the opportunity, what are you going to tell them in order for them to be encouraged and still come for this? Because once someone is afraid, no matter what or how you do it. Yes. So encourage them.
Okay. Thank you. So what I would say is that we usually say the earlier the better. And it's good that you come for it and then you know that, okay, me could try and say she or it's normal than to sit at home and ponder and then wait to make it worse. So I would encourage every woman out there, parents, tell your daughters, grandmothers, tell your daughters to please let them come. Early detection saves life. And like I've said earlier, it's good that you know that, okay, I'm okay, or I have it, but it's early stage, or I have it, it's late stage, so that they solve it early. Because if you decide to wait, you being nervous or you being afraid, it's going to be there regardless. Whether it progresses, it's early or it's late, you'll still be afraid regardless. So I would say that they should try and then get the courage to come, and then the earlier it is than later.
All right. So our time is approaching, and so let me ask the last question. Both of you, what makes this work meaningful? Any moment that really touched you, Helena?
So I would say there was a time somebody in my community, a patient, had pain in the breast. So she came to me knowing well that I work at the hospital and complaining to me about the signs she sees in her breast. So I just advised her that she can just come around for a breast ultrasound. So though she didn't have a request form, I was able to take her through the OPD for a doctor to request to physically examine her and write a request for her. So through the ultrasound, she found out that she didn't have breast cancer. And I really advised her to come because her mother died of breast cancer. So, and we've already spoken about the fact that it can spread from, or if somebody in the family who has a known history of breast cancer can spread to the other person. So after the breast ultrasound, it was found out that she didn't have any trait of the breast CA. So now she was relieved, because initially she was scared when she heard that when a parent or any family member has a history of breast cancer, you could also get it. So after she did the scan, she was relieved that okay, she has confirmed that she doesn't have it, and it's way better than you waiting till it becomes serious.
Sometimes if the thing is not there, and your mind think, oh,
Yes.
my grandma didn't
Yes.
I'm here, I was crying.
Yep. So for me, I would say that I've always geared towards working with people. I like it when I'm doing something for people or I'm doing something for somebody. So working in the hospital has always been a dream for me, because I always want to get in touch with people. So this is like very easy for me.
But you could have also gone to teaching field.
No, I'll lash people. I'll lash them, but I like it when, so when I'm in town and then somebody, oh, I went to this place, lady when they try to scan the mommy. It makes me so happy.
Yeah.
So yeah, I just like doing it, and then it's
sure.
a passion for me. So yeah, it's good.
So our time is up. Your last word. Any greetings that you greet, or your last word? Yeah.
So thank you, and then like I've said earlier, please don't sit at home and then wait until it's late. Whether you detect something or not, come, let's do the scan and then make sure you are okay. And then would like to say thank you to our administration at Cape Coast Teaching Hospital for this opportunity. Our CEO, Dr. Njedu, and all the other board members, and then our head of department, Dr. Dennis Nagala, our in charge, Mrs. Othiamana, and then all the other staff that we work with, both sonography, nurses, administration.
Yeah, we
Yes,
deserve
we
it.
greet them all.
All right, Helena.
As she has said, I would also encourage all women to also pass by to take a breast ultrasound or any of the breast imaging modalities. We shouldn't think it's so expensive to do, but
Now, I won't find him, right?
honestly, it depends as a so just come. If you come and you can't afford, you just go home and prepare towards it. It's better that way than to end up getting an end stage breast CA, and you'd have to treat it with sums of money. And for the acknowledgement, I would also thank my HOD and my colleagues at work at the Cape Coast Teaching Hospital. And we also thank Cafdil TV for giving us this opportunity.
Yeah.
Thank you so much.
All right, that's it on tonight's episode of Cafdil Healthcare. We hope you now understand how radiology supports the fight against breast cancer. Helena Amewude is a radiographer, and Baba Onuma, sonographer, Cape Coast Teaching Hospital. Thanks for watching. I am Kojo Arthur, and this is Cafdil Television. Stay healthy and informed. Good night.
Sorry. me no ma physique. Y'a un concept à fâcher Even Mary, some control, Muraman, Yahoo Twifun, Yasar Mahinda. Even Mary, some control, Muraman, Yahoo Twifun, Yasar Mahinda. Too far. Rain in my hand, now what's in my hand? Yeah, yeah, ain't me I went too far. Rain in my hand, now what's in my hand? Rain my wool, what's my wool, can she rain? I'll cook her food in strawberry. Rain my wool, what's my wool? Can she rain? I'll put her foot inside the I